Hello, everyone. Thank you so much for taking time to join us today for this workshop. Today's session is the first webinar in a three-part series that is called The Roles of Trust and Health Literacy in Achieving Health Equity. I am Lawrence Smith, a physician, Senior Vice President of Northwell Health, and the Dean Emeritus of the Zucker School of Medicine at Hofstra Northwell. I also chair the Roundtable on Health Literacy at the National Academies of Science, Engineering, and Medicine. In today's workshop, we will be exploring what trust looks like in clinical settings, how it can be engendered, and what role health literacy strategies can play in building it. We will also discuss, in turn, how improving trust can contribute to improving health equity. If you have not yet, we encourage you to register for the other two upcoming sessions in this series. Each one focuses on the themes of trust, health literacy, and health equity in a different context. Today's is focused on clinical settings, next week's on public health institutions, and the final one will cover community settings. This webinar is hosted by the Roundtable on Health Literacy. For those who may not already be familiar with the Roundtable, it is a convening body comprised of health literacy experts from academia, healthcare, pharma, community-based organizations, and other fields. The Roundtable holds public meetings such as this one to share promising and best practices and cutting-edge research around specific topics in health literacy. I'd like to thank Rose, Kelly, and Christy, the staff of the National Academies, for their assistance to the Roundtable in putting on this workshop. Today, we will have several panels. We will begin with an opening from Lisa Fitzpatrick, who will frame the session and lay out the importance of this topic. She will then moderate a discussion with several panelists, during which they will discuss what trust means to them in a clinical setting, how they recognize it, and what role health literacy plays. Given that trust is a two-way street, we have speakers who represent the patient side and speakers who are providers who will engage with one another. Next, we will hear a presentation that describes what research tells us about whether health literacy can be a mediator of trust. Lastly, all of the speakers from those sessions will join up to talk about what actions providers and health systems can take and what policy implications there might be. As we go along, submit questions to the Q&A function at the bottom of your Zoom screen. We will do our best to address them. Before we begin, I would like to remind everyone that you can find a number of resources from this webinar at the Roundtable website, nationalacademies.org/healthliteracyrt. You can find all of our panelists' full bios in that page now. In about 1 week's time, the recording of this session will be uploaded to the web page as well. I am now going to hand it over to Lisa Fitzpatrick, who will say a few words about the workshop and what it seeks to address. Dr. Fitzpatrick is a member of our Roundtable and of the planning committee for the workshop. Dr. Fitzpatrick is an epidemiologist at the George Washington University's Milken Institute School of Public Health and the founder and CEO of Grapevine Health. She is passionate about engaging communities in improving health equity by creating trustworthy, accessible health information. Lisa?
Thank you, Larry, and welcome to the Roundtable today, everyone. The need for greater trust in healthcare has emerged as a central theme in our conversations about transforming the healthcare delivery system to become more focused on the needs and concerns of patients and communities. Trust is critical for engagement in healthcare and preventive health behaviors. Trust impacts willingness to engage in care and acceptance of medical advice, and it's measurable by indices like medication adherence, clinic no-show rates, and hospital admissions. Yet, we haven't adopted and standardized measures of trust in healthcare, but I'm hopeful that with conversations like these, along with a body of work emerging from the American Board of Internal Medicine Foundation, we'll get there. The work of the ABIM Foundation is notable and has been published in JAMA, and we will include a link to their work in the chat. In 2019, the foundation convened a diverse group of healthcare stakeholders for comprehensive discussions about trust in healthcare. And although their efforts focus on physicians, these discussions easily extend across the health sector to the broader universe of healthcare providers. So I'm highlighting the foundation's work to emphasize their efforts underway to prioritize trust in healthcare, and we can build on these efforts. Today, we want to emphasize the association between trust and health literacy. We will hear from community members who can make this connection explicit for us through their healthcare experiences, and as you just heard, also from providers. My work has included a focus on the relationship between health literacy and trust, and I have countless testimonials and feedback from community members highlighting how our failures to ensure understanding of clinical guidance leads to suffering and morbidity. I'm humbled by the stories about patients second-guessing clinical advice because they believe doctors are conspiring with the pharmaceutical industry to make money, or believing advice from friends and family over healthcare professionals because it's communicated in a familiar language they understand from a source they trust. I'm humbled by the impact of our inability to speak in plain language. A man once told me, if I don't understand you, I don't trust you. So for healthcare providers and organizations joining us today, I have a specific message for you. The language of health literacy is often communicated as a patient deficit, as if to say a patient's health is failing because they don't understand something. But providers, speaking in plain language is our responsibility, and addressing health literacy is our work to do. We're responsible for ensuring people understand what we say, and it builds trust. As the gentleman said, if I understand you and relate to you, I can trust you. And in our shift to value-based care strategies to address health and social needs of the whole person, what currency can be more vital than trust? So I hope the conversations today will motivate you and your organizations to commit to addressing health literacy as a path to bridging trust with the people we serve. I also hope these conversations will result in a consistent demand for prioritization, consensus, and adoption of quality measures for trust in healthcare. Because after all, trust is essential to achieving optimal health outcomes. So let's turn to our guests. We have a very exciting and experienced panel for you today. I'll ask each of them to spend a minute introducing themselves and telling us what they'd like to know. But in short, the panelists are Mr. Kevin Dedner, founder and CEO of Hurdle Health, Nikki Montgomery, Program and Communications Manager at Family Voices, Melissa Simon, a professor of obstetrics and gynecology at Feinberg School of Medicine, and Reggie Tucker Seeley, Vice President of Health Equity at Zero Cancer. So welcome to all of you. And let's start with you, Kevin. Can you introduce yourself? And let's each take about a minute so that we can really jump into the conversation.
Well, first of all, thank you, Dr. Fitzpatrick and Dr. Smith for your leadership and all of those at the National Academies and everyone who serves on the roundtable. I really am grateful for the opportunity to participate in this discussion and excited to see discussions like this moving forward. My name is Kevin Dedner. I am the founder and CEO of Hurdle Health. We are the leading culturally intentional teletherapy provider based here in Washington, D.C., but providing services now in 9 states. And I look forward to sharing more of my story and why this conversation is super important to me.
Thank you, Kevin. Ms. Montgomery?
Yes, thank you for having me here today. I'm Nikki Montgomery. I am a patient. I'm a patient advocate, and I'm the parent of a medically complex and disabled child. And I also work as a program and communications manager for Family Voices. And our organization is a family-led organization that's focused on family engagement and systems level transformation in healthcare, especially focused on the health of children and youth with special healthcare needs.
Thank you. Welcome, Dr. Simon.
Hello, everyone. Thank you so much for the invite. I'm honored to be here with these esteemed panelists. I am an OBGYN by training and clinical practice right now at Northwestern Medicine, and I also lead the Center for Health Equity Transformation. So I do a lot of research at that intersection of health equity, community engagement, and implementation.
Thank you. Welcome. And Dr. Tucker Seeley.
Hi, everyone. So excited to be on this panel with everyone. My name is Reggie Tucker Seeley. I am the Vice President of Health Equity at Zero, the End of Prostate Cancer. And we are the leading national nonprofit with the mission to end prostate cancer and to help all who are impacted by the disease. We work to advance research, we provide support, and create solutions to achieve health equity to meet the most critical needs of our community. Prior to joining Zero, I was on the faculty in the Leonard Davis School of Gerontology at the University of Southern California.
Okay, so let's jump right in. I would love to hear from each of you with my first question. What does trust mean to you in the clinical context? What does it look like? How do you recognize it? So let's start with you, Reggie.
Yeah, what trust looks like. I think I'm going to bring sort of, my professional experience, but also my personal experience, sort of navigating the healthcare delivery system as a Black gay man. I often sort of talk about this. My personal experience is that oftentimes I have to decide, do I want a Black physician or a gay physician? It's so hard to find both. And so when can I sort of bring my full self to that encounter? So thinking about, the importance of that relationship and whether or not the physician shows up as a trustworthy partner to help me, navigate that space is critical to that relationship.
Thank you. How about you, Nikki?
Thank you. So when I think of trust, I'm usually thinking of it as a patient or a care partner. And when I look at trust in the encounter, to me, it means I'm trusted as well. So it's not just one-sided. It's not the provider, my trust in the provider, but does the provider hear what I say, trust what I say, trust the experience that I bring into it. I have a child who has a lot of complexities, and that means I know a lot of details about his care, and my knowledge needs to be trusted in that setting.
And do you have an example, a concrete example for people that describes a time you gave information to your healthcare provider and they didn't trust that you knew what was happening?
Yes, I mean, I've had many of those, unfortunately, navigating in the skin I'm in healthcare. But one that comes to mind is I was talking about my son's respiratory symptoms. He had a tracheostomy, a ventilator when he was younger, and talking to the doctor about him coughing. And the doctor was very dismissive to me to say, oh, it's just normal that he's coughing like that. I knew it wasn't normal for him. And I knew that the doctor was not trusting what I was saying about my experience with him.
Thank you. And how about you, Kevin? What does trust mean to you in the clinical context? And what does it look like? How do you recognize it?
Yeah, well, first of all, let me just put a couple disclaimers out. I think today I'm showing up as a patient, but I'm also showing up as a provider, but not as the provider who actually delivers care. So I founded a company that delivers teletherapy, and I'm not a therapist. It's my disclaimer, but the company was founded out of my own personal experience of having struggling with depression and not being able to find a therapist who I could form a therapeutic alliance or provider fit with. I was going to therapy, and every time I was going to therapy, I left feeling a little bit worse than what I started. And so really building, I think on what both Nikki and Reggie have both said, after I recovered from my depression, I realized that, the experience I was having where therapy was not working was happening for so many people. And so, I found this company, which the essential thesis is that therapists are not trained in cultural humility and cultural responsiveness, which, I think in this conversation really leads back to the issue of trust. For me, when I was in therapy and sharing my experiences as a Black man, my experiences as a Black man from the antebellum South, and oftentimes those experiences were dismissed. And so, I really appreciated what Nikki said about, sort of trusting you. And I think the experiences I was having with these therapists is that they were not trusting that my experiences were real. And, that it's unfortunately why 50% of ethnic minorities terminate therapy prematurely, is because, they don't feel heard in their therapy sessions. And so trust for me looks like being able to show up and bring my whole self, all of my experiences into the clinical setting. And I think that that's important, whether it be therapy or whether that's with me being with my primary care physician.
I'm curious, Kevin, are there any tells? So is there something you notice right away that lets you know whether or not you can trust the provider?
It's really interesting because I think we've all moved to a place where our lives are very hybrid. My most recent medical visits were all online. And so, you're sort of looking for cues and signals that, I think legitimize the person with you, like this person's going to truly understand me. But, in one of my most recent virtual visits, I took notice to the art on the wall of the provider. And so, I think something as simple as that can send signals to people about your willingness to embrace their culture, or, to embrace the truths that they're going to share with you about them. But it's also, sort of mannerisms and conversations, going back to my experiences in therapy, when I would share experiences about, the microaggressions I had experienced in the workplace, not only was the body language dismissive, but, sort of the response to move on to the next subject was a very dismissive thing too. So, the trust, Lisa, seems to be one of those values or emotions that we might not be able to quantify, with some specific number. But, it reminds me of, what the famous poet Maya Angelou once said: people always remember how you make them feel.
Mm-hmm. Yes, you're right. But I'm glad you brought up this idea of quantifying, because I'm going to ask you each to help us think about that towards the end of our conversation. So just be on notice. So Melissa, even though you're here as a healthcare provider, maybe you also have some experiences as a patient, but how does trust show up for you as a provider? And what are some things you do to navigate this issue?
Yeah, thank you so much. I agree with everything that has been said. We really are at a crisis in our country with respect to trust and engendering trust in our healthcare delivery system. And we see this with all the pervasive health inequities across every condition, every medical condition. So in my view, both as a patient and as a provider, it's an essential first step. As soon as that door opens, or even when you have the first point of contact with a healthcare provider or team or clinic or a system, that first phone call is the step towards that journey of engendering trust. And, if you have a rude experience on the phone, forget it. Why should I even go? Right. Plus, understanding that many of us come to a clinical care encounter with a history of already experiencing discrimination or blatant racism or all the other isms, or our family member, close loved ones, friends, etc. So we bring that with us. So trying to unpack that and addressing that is really important. So things that I expect are deep listening and ensuring everyone feels heard and valued as a member of the team, whether you're a patient, a loved one, or a caregiver, or anyone on that clinical care team. So it is multi-directional, as Nikki said.
And have you ever experienced a patient distrusting you? What was that like? I know I'm putting you on the spot, so even if you don't, it's okay. You can always come back if you think of something.
It's okay. No, I take care of a lot of patients, especially in the obstetrics world, where maternal mortality rates are at an all-time high in our country across all populations of color, pretty much. Trust, we have a deep, dark history of engendering distrust in the field of obstetrics and gynecology. Marion Sims, the so-called godfather of gynecology, engendered a ton of distrust, experimenting on slaves without their permission and no anesthesia. I mean, it's a deep, dark history, and we have to acknowledge that and move forward. So every single clinical encounter on the labor floor, regardless of who the patient is going to get full, deep listening from me, is going to understand that I'm here for them, but sometimes I may be making decisions with the clinical care team that are very fast, because on the labor floor, things move very fast if something's not going right. So I've had a patient not too long ago who clearly had been abused in the medical care system, clearly, and did not want anything, just wanted to be left alone and deliver her baby on her own without any intervention. And unfortunately, there was a lot of complication ensuing, like the fetal heart rate tracing wasn't doing well. And so the baby was telling us that something needed to be done fast, like a cesarean section. And there was a lot of discussion, a lot of resistance. And it really saddened me to have to experience and hear all of the abuse that she had suffered through that medical care system in her past. We got through it, and we eventually were able to do the cesarean section so that the baby could have a better health outcome. But it took a while. We had to pause, stop, and deeply listen and try to unpack everything and clearly explain what we were doing, why we wanted to do it, and really take her lead. Let her lead us through when she was ready to undergo that procedure.
Thank
Lisa,
you. Thank you. Yeah, go ahead.
If I may, I just really want to build on what Dr. Simon has said. Because I think she sort of put this really important nugget in this conversation about systems and institutions acknowledging the role and the history that they've sort of played in biases and mistreatment, particularly in people of color. And there's sometimes this thought, well, that's not the healthcare system we are today. The problem with that thinking is that in our families, we pass on these stories and it becomes like a collective knowledge about how the institutions function. There are just, stark examples of this in the mental health care system. There was a time when enslaved persons would leave a plantation running away and they would be diagnosed with a mental condition. Early therapists thought that people of color brains were too simple for talk therapy. So, these stories are passed down in our family, and a part of building trust is institutions and systems acknowledging these historic tragedies that we know exist, but oftentimes because we live in September of 2022, we see those things as so far away and we're not a part of those. So, at our company, we're very intentional about making sure that people know when we think about their mental health care, that we're designing an experience that works for everyone, not just for a few people.
Thank you both so much for that. And, as I was listening to you, Melissa, talking about the need to make fast decisions in a surgical situation, the worst time, and we saw this over the past couple years, the worst time to try and build trust is in a crisis. And I think hopefully we've learned that lesson, that this is a long game. We need to consistently work to build trust. Both Nikki and Reggie, I would love to hear from you let's talk about this connection between health literacy, communication, and trust. Where do they intersect? And do you have any stories that might highlight the connection between health literacy and trust, particularly if it led to a poor health outcome? So, Nikki, do you want to go first?
Okay, I'll jump in. I think there's a huge connection that we cannot be equal decision makers and equal partners in healthcare if we don't have the capacity to share and use information the same way. So to me, that means making information accessible to people is a key feature of trust. In order for us to build that trust, in order for us to actually be equal partners in power share. So that to me is an important aspect of that connection. And I think so much of the power has still resided in healthcare. When families have medically complex kids, we often get these glossaries of acronyms. So we are being trained on the language of healthcare so that we can navigate, but healthcare is not being trained on the language we use, so that already shows us the power dynamic. The power dynamic is that we're forced to adapt and the healthcare systems just do what they do. So that part can be really problematic. And when I think about health literacy and language in particular, I have 2 degrees in English, so this is a love of mine, but also looking at how we use language. A hospital I was working with was sending home discharge packets with pediatric patients that were their homegoing packets. And that's what they called it. They did not realize that in the African-American community, what you're telling me is I'm planning a funeral right now. So that difference in the one word totally changed the communication. So to me, thinking about language as a way to connect with people and build trust is really central to what I do in general, but it's central to healthcare and central to building that trust.
That is such a powerful example. Thank you so much. What about you, Reggie?
I think an important point to be made here too is differentiating between equality and equity. I think within some systems and among some providers, they may say, oh, I treat all of my patients the same. But I think what's important here is to meet patients where they are. And so making sure that you are recognizing sort of whatever knowledge, whatever sort of experience or background that patients are bringing to the encounter, that's where you are meeting patients. So in terms of the work that my organization Zero does, we try to equip patients with the knowledge about prostate cancer that they need in order to navigate the system, to navigate the interaction with their encounter. And then for my own personal experience, having a training in public health, recognizing that I may bring, a knowledge level to the encounter, I always communicate to my provider, what my background is. And so I try to sort of wrap myself in sort of, that knowledge so that in the interaction with the provider, he or she knows that I bring a little bit, of experience and knowledge to the encounter, both at the population level and at the level of the individual. So that then when he or she is talking to me, they can recognize that is a knowledge base that I have in that encounter, and they can meet me where I am and sort of have that conversation with me as someone who has both the personal experience at the individual level, but also understands, a bit of the data from a population perspective.
Mm-hmm. So what makes a provider system worthy of trust? And if the answer is different from a provider versus a system perspective, I'd like to hear about that too. So I'd love for all of you to answer this quickly. what does that look like? A system or a provider that's worthy of trust?
I think
Kevin,
it's
you want to
important
start?
for.
I was hoping I
Well,
didn't have to call on you all. So just to maintain some order, why don't we hear from Kevin, then Melissa, then Nikki, then Reggie.
You know, I think this is interesting because I lean in here as a provider who's trying to create experiences that make people feel valued and welcomed in our work. And for me, I think it's about the effort. You know, I don't expect for our team or even an institution, any institution, to get this right out the gate. But you know, one of the terms that Melissa has used that I really like is this deep listening. You know, what does it really mean to give people an opportunity, you know, to share their expectations, or even, you know, the space to be heard? And so I think it's all about an earnest effort, not necessarily like we've seen very recently a lot of efforts that are sort of more about sort of PR as opposed to, I'm going to take this term, Melissa, the deep listening that we should all be doing when we're providing care. But I think it's, you know, this is really the goal of what trust looks like in an institution.
Thank you. Yes, I agree with what Kevin just said. Plus, you know, worthy of trust is in the eye of the beholder. I mean, there are things we in the healthcare system absolutely need to do really, really consistently that we're not doing enough of yet. And there's a whole list, and we've mentioned some, including deep listening, providing that space, and making sure every person feels valued and valuable and that they are heard. But you know, we just also need to acknowledge that just because, you know, yo hablo español, like just because I speak Spanish and I'm Latina, doesn't automatically mean I gain every Latino patient's trust. That's important because we all need to build trust with everyone, regardless of who they are and all the intersecting identities.
And I'll add to that from my perspective. Trust looks like transparency. One of the things that always kind of needles at me is that we know certain things are happening in healthcare and nobody has to own that right now because we're not collecting and requiring data on certain aspects of care, including trust. So to me, establishing that kind of transparency would make me build trust at a system level.
So I think it's important that engagement with communities is not viewed as token engagement. That is, that the engagement is real and that the engagement isn't necessarily, you know, just because it's something that's fashionable. So, for example, we see it with conversations around health equity and health disparities. It's something that, you know, a lot of systems are talking about. But what happens after that initial statement? What sort of engagement is actually there after an organization or a system says we are committed to health equity? Committed to health equity how? So it's more so in the actions. It's in the actions and not just that the verbiage around that commitment.
Or simply collecting more data to substantiate the problem. So we have a lot of questions in the chat. So I'll just ask you one more question from me, and then we'll turn to some of those questions. If trust became a healthcare quality measure, how would you measure it? So let's start with you, Reggie.
That is a really good question. And even though we had these questions before, I'm struggling with thinking about the ways in which that one gets captured. Because I think, you know, thinking about, you know, I think a component of it has to be engagement, but sort of, you know, engagement beyond just, you know, a single count. It has to be something that is sort of the quality of that engagement. So, I mean, I don't necessarily have the solid answer for how best to measure that trust. So I'm going to sort of pass the baton, and maybe I'll come up with something as we continue to discuss it.
What do you think, Nikki?
So I have a couple of ideas here. First, I think, we're using HCAPS for other stuff. Let's think about how we can talk about trust there. But also, I think there's an aspect of looking at providers' notes to see how they trust their patients. Patient like said, or patient stated, or patient claims that says, I don't trust what that patient says. So I think there's, again, two sides to trust. So how do we measure it on both ends?
Kevin?
Yeah, I guess I'm gonna sit on this side of the conversation with Reggie. I'm having real difficulty thinking about how you would measure trust. I guess if I was taking like my best guess of how it might work, it would be some combination of questions that might come to sort of something similar to a net promoter score. But, I think Melissa said this earlier, this is all based on an individual and how the individual feels. So, what I want to do, Lisa, and I know you're trying to press time, but I just want to introduce one more idea here into the conversation. And that is this idea of cultural humility. I think we have in healthcare have really misled one another over the last 20 years to believe that we could become competent in one's culture. And for me, really, I want to say, I think trust is about humility, is acknowledging that you cannot become competent in one's culture. So we need to there is a movement afoot to reject this language around cultural competency. And I hope all of you all will join me in that. And we reframe it more as around cultural humility and cultural responsiveness, meaning we're showing up, as Nikki has sort of really tried to point out, recognizing that we may not have the bank of experiences to respond to everyone, but their experiences are true and valid.
And what do you think about this, Melissa?
About both things. Now, Kevin just added one thing for me to comment on. I have a paper a long time ago about that we will never be competent. I cringe every time somebody says, or it's written, cultural competency. Cultural humility and culturally responsive or responsiveness is really the way to go. But with respect to a measure, nothing should be measured until around trust until we first make sure we know what patients and persons and communities themselves want to be measured on with respect to trust and want to measure us on with respect to trust, us meaning the healthcare team. So that's really important. The other aspect to such a measurement would be really clear transparency. So clear stated values and beliefs first of the healthcare organization, community clinic or institution. And then the process needs to be really clear with how iterations of how to achieve trust and how to achieve optimal patient care for every single person. That's really important. And I think that's got to be embedded in different facets of a measurement of trust.
Yeah.
I think a key component that we've all sort of tapped into is that sort of whatever we use as this measure, that it's something that includes the patient in the conversation. So that, if whatever measure it's going to be, that the patient is at the table sort of helping to come up with what that assessment is.
Mm-hmm. We have so many great questions in the chat. I'm going to invite the panelists to respond to some of these, but before we close out, I'll just ask a couple of these questions. One is for you, Melissa. Have you received training on how to build trust within the clinical setting or training to combat implicit bias towards patients? And then the second one, can you all comment on the need to overhaul education and procedural instructions for medicine? Because there's another, and I'm going to combine a couple of questions here. Someone is saying the health system is writ large is talking a lot about transformation and believing that we're doing a better job because we're talking about health equity now, we're talking about bias and racism in healthcare, but I think the question is really, have we really changed? Is the health system really responding to these structural issues that keep people unhealthy? So Melissa, if you want to go first, and then I'll just, for the last couple of minutes, invite others to respond to this notion that the health system still has a lot of work to do.
So my formal training, which is a part of my training, is from my familia, from growing up, having to navigate my own family through egregious abuse of the healthcare system, from the healthcare system, and learning what it really means to build trust. And from that perspective and all those lived experiences, that is my formal training in trust. It wasn't in medical school. It wasn't in residency in terms of didactics or lectures. It was, it was from how I experienced the healthcare system with my family growing up and what I wanted to do and commit to making it better for everyone. I'll let other people answer the other questions because I could start answering the other ones, but I'm going to let other people talk.
The questions about sort of that we've started having all of these conversations around disparities and equity. I think we've initially sort of made a commitment to talking about these issues, but there hasn't been sort of a conversation around what does best practice look like in this space. I am the vice president of health equity at a community organization, and I've talked about with several of my colleagues, there isn't a space for those of us who've assumed these new roles to come together and talk about what are best practices for how or what does health equity look like in these spaces. So I think we do a really great job of talking about or of having the initial conversations. But what happens after that initial commitment? And what does that look like for patients in the clinical encounter and in the community?
And either Kevin or Nikki, do you want to close us out on that? Kevin, Nikki? Kevin, you're on mute.
I have another question I'm itching to answer in the chat,
Okay.
if that's okay.
Sure,
I
go ahead.
see one talking about the ideas for ensuring that we're heard. And I think this is really important, especially, the person who posted it said being a Black woman and seeking healthcare. This is something that I've gone through myself. I've gone through several phases of it. Do I show up as, soft and congenial and all of these different things so I can be accepted? And why am I bending who I am to be accepted in this space? It's been a whole journey. But to me, the way to be heard is to continue to exercise your voice. I have pushed back and been seen as pushy. That means that provider is not the provider for me. Sometimes that means there's not a great continuity of care while I seek another provider. But I am determined to find the relationship that is a fit for me so I can have that trust. And if someone thinks I'm too pushy, then we don't have that relationship. If someone's judging me by other factors than how I present in that moment, then that's about the relationship I'm building, and it may not be a good one. So to me, that aspect of being heard is something that I struggle with a lot and have struggled with, especially because I was caring for an infant. And what happens if they think I'm pushy? Do they then not give him the level of care that he needs? That's a terrifying thing. And that power dynamic plays into that a lot. But to me, it means you have to continue to exercise it and find spaces where it's safe to do that and where someone respects how you show up.
Well, thank you all so much for such a rich discussion. But for our audience, don't worry. These speakers will be back in a little while for our final panel. But for now, I'm going to hand this off to our next moderator, my colleague, Dr. Michael Wolf, who will introduce our presenter and then facilitate the final panel discussion. Michael Wolf is an Associate Vice Chair of Research at Northwestern's Feinberg School of Medicine, and also directs the Center for Applied Health Research on Aging at the Institute for Public Health and Medicine. As a cognitive behavioral scientist, his work in health literacy has centered around psychosocial, cognitive, and health system determinants of health in the area of health literacy and health communications. Michael?
Great. Thank you very much, Dr. Fitzpatrick, for the introduction. Following the great panel discussion that you just heard about the nature of trust, we're going to turn it over to our next speaker, who will be presenting on the state of the research around health literacy's connection to trust. So Dr. Michael Pasciarello is Professor of Medicine and the Vice Chair for Research in the Department of Medicine at Tufts Medical Center. And while he wears many more hats, I am also honored to call him a dear friend, a longtime collaborator as well. Michael's current research centers around health literacy, doctor-patient communication, and empowerment, and he has worked to design patient empowerment and decision support tools using health literacy principles. So Michael, on to you.
All right, can you start the slide? There you go. Can you see my slides there?
Yes.
Okay, thank you. So thank you very much for having me. I actually really enjoyed hearing the panel, and I think there's a lot of things that will tie into what I'm saying. But let me jump in. Health literacy and trust. I think I took this, I take this opportunity to review the literature and really to get a sense of to what extent are these overlapping or connected phenomenon, and to what extent they actually are explanatory with respect to health outcomes and with for racial and ethnic disparities. And I took the opportunity to read about 70 papers to think about today's talk, and I'm not going to share details of all the papers, but I will share some of them, and also just to give you a sense of the range of what's out there and how this is looking at this point. And I know I was directed to think specifically about the clinical context, but actually the other parts of this puzzle have a massive influence on the clinical context as well. So I took this a little broader, as you'll see. So the first thing is to what extent is the evidence balanced in one direction or another. So actually the first part of this that I wanted to focus on was about critical appraisal. Critical appraisal is a fairly important feature of health literacy and how people engage information in the world, and what that looks like. So there's actually a fair amount of research in this space. And it's kind of exploded in the context of COVID, because COVID has actually been like an infodemic, has been a massive explosion of information, and people have been yearning to get it. So, I can't really see the top of my screen, but it'll work out. So here's an article that shows that that health literacy does increase. Higher health literacy is much more likely to lead to people finding medical information through medical websites, and that in decreasing the chance of getting your health information from TV, social media, blogs, subreddit web pages, and the like, and that people with lower health literacy just have much more trust in TV and social media, blogs and celebrity web pages, friends, and even pharmaceutical company websites. Kind of maybe as you might predict. Here's an article about COVID and information sources, and respondents with higher health literacy had more trust. Actually, this is kind of in the opposite direction. People with higher health literacy had more trust over various sources. Interpersonal trust. Interpersonal trust is really the domain of how the clinical encounters work, and so in this respect, what's the evidence there? In this paper, there was an independent relationship between inadequate or marginal health literacy and physician distrust. So so people with lower health literacy had less trust in their physicians, but actually there was no association with institutional distrust in this project. This first project was from the Vanderbilt group, the inpatient survey at Vanderbilt, and here's another paper also from Vanderbilt, actually, which showed the opposite. Actually, in this paper, also from Vanderbilt, different population, different study, lower health literacy was associated with greater physician trust. Actually, the opposite. Here's another project which showed that health literacy significantly positive association with trust in the physician and also trust in the healthcare system after adjusting for associated characteristics. So here it's like, maybe as you might hypothesize. And here's an opposite paper by Darren DeWalt and Michael Pignoni, which basically showed there was lower literacy was not associated with trust with the physician. So the next section is about organizational health literacy and trust. In this project, lower health literacy was associated with decreased trust in the health system. Basically, that people with lower health literacy felt that the health system was not cooperative with their needs and goals. In this project, actually, higher health literacy was also associated with lower trust. And in this respect, they had higher expectations about the system and about the quality, and they were just disappointed and unhappy, and led to lower trust. And actually, the lowest amount of trust was in the middle group of health literacy in this study. Maybe at a societal level, it's would be fair to point out there's been an explosion of interest in this topic because of the global pandemic. And so I couldn't resist to take the opportunity. Here's a paper by Mike Wolf showing that health literacy was not a significant factor associated with vaccine trust, and another paper that showed the same, not significantly associated with trust. Actually, I have our own manuscript under review, which showed that health literacy was an important mediator of trust and vaccine confidence, mediator of racial disparities in vaccine confidence. And then another analysis that we'll try to get out as fast as possible is showing that also a mediator of uptake of vaccine disparities. So let me just, so I set the stage with these different categories: information, interpersonal, organizational, and societal. And I want to just say, when you look across these studies, they're really pointing in a lot of different directions. And part of this is because the domains of trust are just very poorly captured and quantified. When you think about trust, you could start to talk about, well, what do you mean by trust? You could say, well, I want this to be fair. I want the information to be fair or accurate. That could be your focus. Or you could say independent. I don't want to, undue influence from outside sources. Or transparency, that was brought up a few times earlier in the previous panel. Or that honest, and that actually could be different. These phenomena might be somewhat different. Confidential, I trust that you'll actually keep my confidence here. Or authentic. I mean, you could say, I trust this doctor to represent their authentic view that's authentic for them, but I don't agree with them. So reliable. This is a very, very important element of trust that sometimes I think is not focused on. And devoted to me, as opposed to say some other thing like the state or public health. So, part of the reason why I think that the literature is so confusing is that the domains of trust are really not actually appropriately differentiated and vetted out. But there's also very different outcomes that are being discussed here. Most of them are about subjective reports. Some of them actually focus on agreement or consent or adherence. And so the outcomes are all over the place. And ultimately, there's other issues here too. The projects are done with different populations, in different places and times, in an incredibly fast evolving information climate. What was normal even just a few years ago is actually off the books. You literally can have, I had a patient who said, who said to me, thank you for sharing this information for me, but I'm going to have to go get my own information. Meaning that everyone's allowed to have their own facts now in some respects. And in some respects, the information that comes to people is routinely vetted through algorithms based on things that they've searched for, things that they've said. And so in some respects, you can say, do I trust the information that I'm getting? Reflects actually how accurate the algorithm is to just provide information that confirms your prior beliefs. And so the kind of the information landscape has rapidly evolved. People actually frequently don't engage with information that's not just confirming their prior beliefs. Another thing that I think is really important to point out is that this literature is messed up in part because health literacy is defined in so many ways and measured in so many different ways. And this is something that the health literacy house, so to speak, needs to clean up. But there's something that's evolved in the definition of health literacy that I think is actually leaning in the right direction, leaning towards a more trustworthy scenario. And this is the old definition. And I always had beefs with it, but one of my main beefs with the traditional, if you will, definition from Healthy People 2010, Healthy People 2020, is that it focused on the capacity to obtain process, to make appropriate decisions. And I submit that that is just not a trustworthy stance. That is to say, appropriate to whom? Why is it about appropriateness? In fact, the new definition from Healthy People 2030, at least for personal health literacy, drops the appropriateness. And I'm very supportive of this. I was an advocate for this for a long time. And that the goal of health literacy is to make informed health-related decisions and actions. And I think that's a very positive step forward. So where does this leave us? If you look at all this literature, I hope you don't despair. It is a mess. It's a mess right now, but I think there are some key things to think about. But before we get to that, I think we have to step back and look at the broader terrain. The health literacy and trust literature really should be thought of as sitting within a broader, larger trust literature about health and health outcomes. And it's been a very important element of many efforts to think about racial disparities. It's actually been one of the explanatory paradigms that have been advanced for racial disparities. And I think it's actually super important to step back and think about that and to look at that for what it is, because in part, it's very, there's some problems there. Let me explain. The basic underlying principle of much of this literature, implicitly, maybe even explicitly, is you don't trust us. This is very othering. This is really not an engagement with people that's productive when you kind of look at this in a, I think with honest glasses. And let me just give if you're not with me on this already, let me just give you a very specific type of example. The most common thing that in the discussion papers about this is to point to Tuskegee. Now, we have to talk about Tuskegee. We should not hide from Tuskegee. However, let me just reflect a bit about one thing that Tuskegee does in many of these papers. Tuskegee, talking about it the way that many authors do, effectively says that was something that happened far away and long ago. And still you don't trust us? The othering implicitly built into referring to Tuskegee and not to think about the broader context is disturbing. And so what I would want to push us to is to really think a little broader. So in some respects, there's a cycle of mistrust that's built on people's experiences. You can't actually come into a room. You can't imagine, oh, I'm going to now be in a room with a patient and neglect the fact that actually that it's mistrust is reinforced, that people see that there are major disparities all around them, or they experience themselves. They see that there's discrimination in their life in healthcare, and they see that actually people that there's not transparency around healthcare and healthcare research, and in turn there's not participation in studies, and in turn there's research that's actually not generalizable and actually deepens health disparities, and it goes around again and again and again. But actually, that's even just the tip of the iceberg. That whole cycle is really within a broader landscape of tremendous other problems, in not just in the carceral system, the education system, housing and banking, in public health too. 1 in 3 Black men will be incarcerated. About half of all the money that's spent on every school student in public schools around the country are paid for by local property taxes. This just embeds into the system intergenerational education disparities. It just goes on and on and on. So when you think about these, when you think about public health, for example, we're hopefully coming through this massive global pandemic. One of the main things that people said was, social distancing, fantastic. Many people said, okay, good. I'm going to have my food delivered to my house because I'm going to do social distancing. But when it comes down to it, there are people who get their food delivered and there are people who deliver the food. And, so we actually have this, all of these phenomena are surrounding this conversation of, what's happening here between these people when they interact with each other in a doctor's office. And we're hoping for some kind of a trust there. So I want to shift the story. This is, I'm not the only one, who talks about this, but I want to shift the story to what does it mean to be trustworthy? And it's high time people are thinking about this, not only me for sure, but shifting towards trustworthiness will take a lot of effort. And there's some things. Now, many of these attributes that I mentioned before, I made this up, faith card. I could have called it like eggplant or something, or maybe cougar or something. No, but I came up with faith card. These are many of these attributes are very important. Reliability, for example, even if the patient does not understand anything that the doctor is saying, on rounds in the hospital in the morning, when the doctor says, I don't have time to talk to you about that right now, but hey, I'll come back this afternoon. I'll talk to you more about that later. I see this all the time. If the doctor does not come back that afternoon to talk more, they proved themselves to not be reliable. And this happens all the time. Even if the patient knows nothing about the jargon that you threw out, which was anyway also completely not trustworthy, they could see that you weren't reliable. And that's like a key, all these things are key elements, but there's additional things that in shifting towards trustworthiness, I think it's key to think about. Caring, listening, being empathic, being attentive. It's just not trustworthy to be on your computer typing throughout the whole clinical encounter. Not being rushed. And here's the last thing that I need to focus on a bit here is to be non-judgmental. When we were starting to distribute COVID vaccinations in Boston, I started having a bunch of experiences where people weren't interested in them. And it was painful to behold. And we didn't know exactly what to do and how to move forward. So one of the things we did was we created RJCs, restorative justice circle work. So we brought together 30 African Americans who were refusing vaccination and 4 providers, and we had a series of 6 hours together in different groups, and discussing the whole discussion was about experiences of racism and how that in healthcare and how that influenced people's choices about the vaccinations. And this was a really, in some ways, extremely painful to behold, and but also extremely useful because it was fantastic. It really burned my judgment out of me around these things because it wasn't useful and it wasn't listening to people. The whole idea of restorative justice circles is people get to speak their truth. And this was brought up, I think Nikki brought up this issue earlier about power and truth, absolutely critical. But let me turn towards the health literacy side of this, because I do think health literacy can be an important part of the path towards trustworthiness. Absolutely. Just some examples before I close out. We could talk about patients' critical appraisal skills, or we could simplify the materials. That's first base in health literacy. We could say, oh, well, when the communication is hard to understand, the patient needs to have more trust. Yeah, but we need to actually talk more plainly. Jargon is less trustworthy. We could say, oh, well, there's complicated health systems and everything. Patients need to have more navigation skills, or we can actually turn hard towards organizational health literacy. And so with that, I'm going to stop because I'm hoping that we can have a discussion about some of the ideas that we put out.
So thank you very, very much, Michael, for a wonderful presentation in really kind of driving home the complexity that exists on these type of topics, that there's a lot of much bigger issues that kind of really frame all of this conversation. So I have the pleasure now of reintroducing our panelists from earlier, with Michael actually joining us as well. All of our speakers have been asked to consider what all of today's discussions tell us about what needs to happen next. What are the action items and policy implications of these issues? What can clinicians and health systems do to improve trust and improve health equity? And how can health literacy interventions be utilized? So this discussion will take us to the end of today's session. And as a reminder to our audience, please share any questions you may have by the Q&A at the bottom of your Zoom window, and I'll do my best to bring those into the mix. So, I really appreciate all of the presentations that started this workshop off in the morning. And I want to make sure we get to hear everybody on those larger questions, because I think this shift in this session is really about coming up with some very specific examples of maybe health literacy interventions that might impart trust, whether that be something broad or maybe you even have a very specific issue in a particular healthcare context. I'd love to hear from you. I was wondering, though, if I could start with Reggie, because you really left the last session with a very important topic about, is there anything? I mean, it's great that we can be talking about this, but do you feel from your perspective, are there any good examples that you've seen of health literacy addressing trust?
Well, I think one of the reasons I often get asked, since I recently left academia to assume this role. So one of the reasons why I left, and I feel like we were doing a really great job of talking to each other about health equity as academics, but we were not pulling in, community organizations and the community into those discussions. And so, as Michael was presenting, I was thinking about the ways in which we expect patients to navigate the healthcare delivery system, and oftentimes we assume that they are experts in that system. And as we are sort of working with patients, do we expect them to know how to do it? So do we tell them what to do, or do we show them? And oftentimes we tell them. And so within my organization at Zero, we try to create as many tools as we can to help with that navigation, so that we are a trustworthy partner to help them navigate this oftentimes very uncoordinated healthcare delivery system of how do patients go from community to primary care to specialty care, back to primary care, back to the community. And oftentimes we expect people to know how to do that without a partner or a coach or a guide in that process. And that's sort of, that's at the heart of what we do at Zero in helping patients to navigate the complicated healthcare delivery space.
So just to follow up that before I move on,
Sure.
is that in the health literacy context, kind of like it sounds like you're talking about like giving the full patient journey, so people have the anticipatory guidance of, in your case, prostate cancer, and helping patients know. Is that a bit of what you're?
Yes. So that sort of help in that journey, but also help in sort of what to ask at each stage.
Perfect.
So what are some questions that you need to ask in your, in your visit?
Can I ask Nikki a similar question? And even if you're thinking from physician communication to the health system, and just how, maybe a follow-up to your thoughts on that. What is a good health literacy trust intervention?
One thing I'll say what it's not. I think I can focus on that a little bit. I've heard a lot of professional social workers talking about how to measure health literacy in patients. And I really think that's kind of a waste of time. Michael, you said this in your presentation. I think of health literacy as accessibility. And so I have a sibling and a son who have disabilities. I don't want to measure how well they can walk up a stair. I want to make sure they have a ramp. And so measuring someone's health literacy is putting them through a gauntlet, when ultimately we should be building materials, building tools, building communications and pathways that don't require them to have a certain skill level. We should be able to make this universal. So to me, don't do that is my first piece of advice.
Thank you for that. I was going to go to Kevin. You shared some amazing patient perspectives and experiences. Do you have any examples of what was done right? Or I guess like Nikki too, you could flip it on what was done horribly wrong too, in terms of prior experiences.
I was throughout this conversation, I've been thinking about one of my very early experiences in public health, in which I actually got it very wrong. I was running a state HIV/AIDS program, and I was announcing some changes to our formulary. And I should have known better. And I'm ashamed to admit that I didn't know better. So I wrote a letter. I was proud of how the letter was written, and I was flooded with phone calls for the next 3 weeks. And then what I realized is I wrote the letter at a higher reading level than what I should have wrote it. And that was like one of it's a really simple thing, but when you think about the population that I was serving and how important that communication was, I mean, it was literally a life saving communication, and I got it wrong. And I had to spend, the next couple of months, correcting that wrong. And so, I think for me, it's really just, I'll go back to this term that I introduced earlier, is the humility. When I wrote the letter, I was how proud of how my subject and verb agreed and how concise I had made it. But, the folks who were getting the letter didn't understand the letter.
That's a very great example that I feel even we've known quite a while through the health literacy research that just, being just plain clear, we still have, I think we all could probably go within our own health systems or organizations and find great examples where we're still not doing it right. Thank you, Kevin. I'm going to go to my dear colleague and Dr. Melissa Simon here. Melissa, you want to weigh in maybe? Are there any initiatives going on through your center in terms of how you're trying to, or even maybe in medical education, about trying to address trust and health literacy from the physician communication with patients perspective?
Yeah, thank you. So 3 things come to mind just from what we're doing at Northwestern and around the country. So one is really designing and testing trust building questions for the first perinatal care visit for all perinatal care providers. We're testing them now, but how many times has a pregnant or birthing person come into their first prenatal care visit and just been dumped on with a pile of information? And I mean a pile of this, plus things that are really complex, even for me to understand, like genetics testing, genetic screening. So taking a moment and pause and considering, just talking about, well, what are your expectations for this pregnancy? What are your hopes and dreams? What are your fears with respect to care and this pregnancy and this birth? So that's one thing. Another thing is checklists. We do a lot of work around checklists, understanding that in aviation, what makes aviation so safe is the checklists. So we have a few different checklists for cancer care delivery and survivorship care and for perinatal care around what is exactly, it's basically a Gantt chart, a planning chart of all the things that need to be done during your specific journey. So whether it's breast cancer surgery first or your perinatal care for the first X number of months, 9 months. And it literally is all fit on one page with check boxes. And what that does is it imparts agency to the patient and their caregiver or their loved one, because if a box isn't checked, then it is easier, regardless of your health literacy level or your language, to say, why isn't this box checked, doc? And that helps bring and evolve the conversation. And on the back of that piece of paper is all the contact numbers as well. So it's kind of navigating patients and imparting health equity, consistency of quality care, and also some patient agency. And then finally, on the labor floor itself, If someone needs, as we heard from Dr. Fitzpatrick, in a crisis situation, which is what sometimes we find ourselves in on the labor floor, we have to move fast, but communication is really important. And so we have a checklist, a very simple timeout checklist that requires for any patient going to the cesarean section room to get a C-section from the labor floor, we have a quick timeout with the patient in the conversation, the nurse, the provider, and anyone else on that care team, the anesthesiologist, around why that person needs a C-section at this moment. And we answer questions with the patient right there in front, and we're doing it together as a team.
Thank you, Melissa. I appreciate that. That's a great example. Moving on to Michael, you did present, this linkage between, how health literacy kind of relates to trust. And maybe a question to you too, given you've done a lot of work in this, is how do you define what does a health literacy intervention look like in the context of trust? I mean, I think we use the term health literacy a lot, and I know Nikki brought it up too. It's a term that, has kind of diverged a bit. So I guess what does that look like to you?
Yeah, so I would say that one of the nice things that I love about this field is that we get to be intensely interdisciplinary and multi-methods, So whatever the problem is, you have to figure out what's the best lever for this, what's the best way to approach it. And sometimes it's at the patient and family level, but sometimes it's at the provider or clinic level, sometimes at the system level. So it really depends on what the issue is. Let me just give you an example of something about information and how these clinical interactions go. Patients are looking are looking at online, people are looking at stuff. And one of the most common things that happens when if the patient says, well, I read on this website, one of the most common things is that the providers clam up. They get defensive. They're looking to stop that. And actually, you should be like, I'm excited that you're interested in your health and that you're going to do something about it. And I'd love to help you with that. Show me what you're reading. It's actually move with and towards the person, not claiming. It's just not trustworthy to say, no, I won't even look at this. That's an example of where the intervention has to be with the providers, or just to say what will the medical home look like of the future? And the medical home needs to actually have a massive investment in patient empowerment. And that not all of that will be the physician. That we need to have a whole range of people in that medical home to make that work. And that's an intervention that has to happen at the system level, or, include things like organizations like Reggie's and organizations like Kevin's, and people like Dr. Lisa on the street, this has to be it's not only going to be one thing, it's going to have to be really quite diverse. So I would say it depends on where you're going to have a lever on this problem. But if you're thinking to shut down people's access to information, that's just not trustworthy.
No, I think no, it is a challenge, and I think the idea that I think Reggie brought it up with what he's doing at his organization in particular about just making information accessible and letting people dig as far, basically project out and get as much information so they know what's coming, not just where they're at. I think asking those examples of giving people questions, it reminds me of, and I think one of the questions in the chat is, where is pharma in this space? And I go back to I think it was probably the early 2000s when Pfizer was doing the Ask Me 3, which I don't think it maybe caught as much traction, but it definitely was this idea, and maybe you're doing this, Reggie, how do you give them questions, just some, even if it's generic questions, something that gets the ball rolling to empower patients. But I'm also curious, and maybe I may come back to Kevin, I think what seems to has resonated a lot in the first panel is your term humility, being at the core of this. And again, I offer it up to any of the panel. I love Kevin, if you'd like to jump in. What very specific, beyond just the provision of information, which I think is the way we think of health literacy, are there other things that we can be doing either at the provider level or the health system level, like Michael said, or at the community level, that would impart that in a way, whether it be training or education or and thoughts on that?
No, that's a great question. I appreciate you circling back here. At Hurdle, we train our therapists in an evidence-based technique that helps them improve their cultural humility and cultural responsiveness. The technique was invented by Dr. Norma Day Vines, who's a professor at Hopkins. It's specifically for counselors and licensed social workers. But I do think that there are some lessons around humility by, visiting Dr. Norma Devon's work that, others in medicine can pick up. So, part of this is that we have to make this very actionable. Like, what can people do as opposed to like sort of what we talk about, and, thinking about how we train our medical professionals, how we train our clinicians is really a core part of it. I think it does actually go back to how we train our workforce and how we're thinking about our workforce.
I think what's also important here is the point that Michael made around Tuskegee. So this notion that historical discrimination is there. We're aware of it, but current discrimination is present as well, that many people of color are managing as we navigate the healthcare delivery system. And so recognizing that both of those things together are contribute to the trust issues that we see in the healthcare delivery system. And then I think the other point is sort of differentiating equity and equality. That is this notion that we're just going to treat everyone the same. So then there are no issues if we are providing equal care, as opposed to equity, which is meeting the patients where they are and recognizing that it takes a lot of effort. That first you have to understand where they are in order to meet them there.
Another theme I've seen a lot is this idea that we should trust. Like, there's an expectation that patients should trust their doctors. And that doesn't hold true for all populations of patients. The trusted community leader may not be who you think it is. We're also expected to trust police officers, and that doesn't always fly in other communities either. So this idea that trust should be demanded almost, or expected, or almost even shaming patients for not having that trust, I've seen that come up a lot. And one of the things I've realized for myself is that, as involved as I am in healthcare, I don't trust healthcare. I'm there because I want to peek behind the curtain and see how the sausage is being made. I'm not there because of a high level of trust. And so this is not a reasonable expectation for people who are currently experiencing harm.
And then there's the flip side of what Nikki just said, is that from the provider's perspective, you're kind of socialized through this medical training to not trust patients, especially certain types of patients. And those biased mental models persist. And then even the language around sign out time, or when you're trying to relay a message about a patient, that can bias you before you go in the room. Well, that patient's being difficult because they are not wanting to do what we want them to do. And that just, it spirals downhill really, really fast.
Michael, I think you had a hand up.
Oh, just thank you. So I absolutely agree. We can't be demanding here. Actually, we have to, I was saying we have to lean towards being non-judgmental, actually, to try to get people to understand where people are coming from. I have a project in Montgomery, Alabama, and we have about 18 community health workers, and it's a health literacy project. And so we've been training people in Teach Back, and they've been working on this. And actually tonight, even, we have another training. And one of the things that's been coming up a lot is, we're doing the Teach Back, but what do we do if the person just doesn't agree? They can tell me back, yes, this is what you said. I don't agree. And so, so we do have to kind of figure out what parts of this are about health literacy, what parts of this are about other things. And, if the nature of the disagreement is, no, I know that there are microchips being put into people's shoulders with the vaccination, so I don't agree. Like, that's one type of a thing, but there are many other types here. And so you have to listen to people, and you have to hear where they're coming from, and somehow to do it and park your judgments someplace else. It's just not going to work.
Are you non-compliant, or do you actually have a say in your own health? And are you a partner in research, or are you the patient, to be heard? Nikki, you're nodding your head.
Yeah, compliance is its own dynamic, right? That's a power struggle too, because is the goal health? Is the goal compliance and obedience? And then does that create a conflict when we don't have an agreement? So that dynamic itself also plays into this whole power struggle and power issue. And what is my agency as a patient to make my own decisions? And how do you facilitate the best decision for me to make for myself?
We only have a couple minutes left before I forget. Cindy Brock dropped into the Q&A. Cindy is a huge champion of health literacy, longstanding champion of health literacy through the Agency for Healthcare Research and Quality. Into that issue, I think especially a lot of the work that Reggie's talked about is doing. There are questions are the answer as an initiative through ARC, and I put in the link to that. And I think if you stay on that website, arc.gov, you'll find a lot of other health literacy resources that are really trying to address the healthcare system and how it can become more health literate. And hopefully that would lead to trust. We only have literally 2 minutes. If I were to just do a quick fire round, if you had 15 seconds or less to just basically say, if you had one thing that you want on your wish list to achieve trust through a health literacy lens, how about, what would it be? Policy or practice? You get, this is your chance. I'm going to start it off with Kevin.
Yeah, I think I'll cheat and just say it's practice and policy. What can we add to the practice of people daily? Can we reinforce that through policy that supports institutions and encourages institutions to embed these practices?
Great. How about Nikki?
I would say plain language is a great place to start. So start communicating plainly to people and make that as simple as possible. And that is one starting point to build trust.
Melissa?
Diversify the workforce at all levels, including leadership and C-suite.
Reggie?
Ooh, Melissa, that was a good one. I had one, but I love that one. So my yes. But mine is, the difference between equity and equality. Make sure that everyone sort of knows that difference. And that is one of the lenses that through which this work is applied.
Amazing. Yeah. Michael?
I agree with all these. These are great things. I think we have to just massively improve how communication happens. This is on the empowerment side, but even just, I have a project now where basically I've shown that no one that I bring in to look at the CDC website can answer basic questions about COVID. No one looking at that website can do it. None of my patients can do it.
Your final wish list, I got to keep you to time.
Final wish list. Today, I'm just going to say, engage people in a non-judgmental way. That's what we've got to start with.
Great answer, and ditto to all of the above. So I want to note the time and wrap up this discussion. And again, thank you to all of our panelists for sharing their insights with us throughout this session. I'm going to hand it over to Dr. Smith to share some last bits of information with our audience and close it out. Thank you.
Thank you very much. Fantastic presentation by every one of you guys. Before I close this out, the business part of it, because it's pretty boring, I just want to point out to you that besides being the founding dean of a medical school that now spends probably 50% of our time with simulated patients teaching communication skills, I was a practicing primary care internist for 25 years. And one of my senior partners, when I was really frustrated by not being able to have the connection with the patients that I wanted in a hurried atmosphere, I said to him, okay, his name was Reese Alsop. I said, Reese, tell me, what is your secret? And he said, well, the first thing is you got to meet the person before you meet the patient. Even if it screws up your schedule, you got to only talk about who they are before you ever get to why they're there that day. He says, that's the first thing. Never look rushed, ever, no matter how bad your schedule is collapsing on top of you, never look rushed. But he said the one thing I learned, believe it or not, he was a theater major in college. He says was, you need to not worry about being yourself. You need to be the doctor that patient needs that day. And I never forgot those words. And everybody has mentors to stick with them. That one afternoon of talking to him was my mentoring for like the next 30 years. And I think they all touch on how you get trust. I'm not so sure about health literacy, but certainly how you get trust. And a lot of things just fall in place when that happens. So on a logistic note, 1 week from now, all of the audience will be able to find the recordings from this webinar on the event page. We hope you'll consider attending the next 2 sessions of the workshop to complete the series and deepen the conversations. Next session is September 28th from 1 to 2:30 and will be on governmental public health institutions. Final session will take place October 6th, same time, 1 to 2:30, and will center on community context. If you'd like to receive notice about future webinars, look to the Roundtable Health Literacy website. And thank you.